There we go. Welcome to this live virtual event from Vision to Action, unveiling the National Black HIV Prevention Research Agenda. This is an event that is very on time and very urgent right now in the current political climate. And we thank you for taking time out of your busy schedules, because I know we are all busy right now, to join us on this important day that we're unveiling our National Black HIV Prevention Research Agenda. Please put your name, pronouns, affiliation, if you have one, and geographical location in the chat so that we can know where people are logging in from. As I mentioned, this is sponsored by the Prep and Black America Coalition. If you're new to PIBA, PIBA is an intersectional social movement. Prep and Black America, also known as PIBA, is an intersectional social justice movement rooted in taking out the structural and systemic issues that are plaguing the Black community from uptaking pre-exposure prophylaxis for HIV prevention, right? We talk about racism. We talk about all of the systemic barriers that affect our population's ability to access and take full advantage of pre-exposure prophylaxis. And today, we'll be focusing it on research, right? The research paradigm, which we all know is under attack right now from the current administration / regime that we find ourselves federally. But we are going to press on, we're going to resist, and we're going to continue going forward. I would like to first start with this video from Senator Raphael Warnock on the the necessity for this research agenda. Hope you all can hear it. Hold on, let me just make sure that, yes, everything is all set.
Hello to the Prep in Black America Coalition family. I'm United States Senator Reverend Raphael Warnock. I want to start by welcoming you to the Advancing the Movement event, celebrating the release of the new research agenda outlining how to eradicate HIV diagnoses among Black people. This is such important work, and I cannot underscore enough the importance of your continued dedication. So thank you very much for staying in the fight, working to end HIV and the stigma associated with the disease is something that I've been committed to for decades. In many of the cities and places where I've worked as a student, in my early years as a pastor in New York, in Baltimore, in Atlanta, and I've seen up close how the unholy trinity of stigma, silence, and shame create pain not only for the person who is dealing with the disease, but to those whom they love. And on top of this, we've seen recently the HHS Secretary, Robert F. Kennedy, laying off the entire staff of the National Center for HIV and the Office of Infectious Disease and HIV/AIDS Policy. This is reckless. These efforts need more funding, not reckless mass firings. So know as we navigate these unprecedented times, I will remain engaged in the fight. I will be your steadfast pastor and partner in this important work. Continue your amazing work, and thank you again for your commitment. Keep the faith and keep looking up.
Great. And just a few housekeeping. Please post any questions or comments that you have in the Q&A section. We'll get to that at the end of our moderated discussion. We're going to have at least 25 minutes where we get questions and comments from the audience, from you all. And the webinar is being recorded, and you all will have access to the video via a post email after this webinar, probably tomorrow morning. But again, thank you so much for being here. And now I will pass it on to my colleague, Danielle Campbell.
Thanks so much, John. And what a great framework to start our conversation in on the heels of the supportive words of Dr. Raphael Warnock. Love a good inspirational conversation. Unfortunately, I'm unable to share, or sorry, I tricked you. I am able to share slides. All right, folks, good morning from the West Coast. My name is Danielle Campbell, as John mentioned, and I am one of a dynamic group of Black advocates, professionals, leaders, thought provokers, agitators, people deeply concerned about HIV prevention in Black communities. And we collectively comprise the PrEP in Black America Coalition, and our work, as John mentioned, has been nested within unpacking some of these systemic and structural factors that affect Black people's unadulterated ability to access HIV prevention in this country and globally. And we do that from an unapologetically Black framework. And we do that by interrogating historic systems of oppression that prevent Black people from actualizing our most full scope of sexual health. And so today we are beyond proud to unveil our research agenda, our National Black HIV Prevention Research Strategy. In this conversation, focus on doing right by Black people, a Black HIV prevention research agenda, and our commitment to stay in this fight until we end this epidemic in Black communities. So just a bit of intellectual housekeeping. We hope to overview components of this first ever Black-led, Black-focused, and Black-centered HIV prevention research agenda. We hope to describe some of the factors to support this research agenda. And lastly, and most importantly, we hope that you all will leave us today understanding your role as an implementer of collectively, our HIV prevention research agenda. There are lots of factors that are happening nationally and globally that will increasingly negatively impact Black communities. And so we hope that at the core of the work focused on HIV prevention, this research agenda will tie together as an anchor. So just a bit of background on PrEP in Black America and some of the many facets of our strategic organization. We focus on advocacy and mobilization. This conversation became to be from an off-the-cuff conversation between Dr. Dawn K. Smith, rest in heaven, and Leisha McKinley Beach in advance of the 10th anniversary of the FDA approval of oral Truvada for PrEP. And there was this overlasting sentiment that, 10 years after, or nearly a decade after, the promise of HIV prevention was not actualized in Black communities, and we wanted to understand why that was. And so through that communication with those lovely leaders in this work, PrEP in Black America was launched to address these systemic and structural barriers that, as I mentioned, impede access to PrEP in all of their modalities in the Black community. So to that end, we hosted the nation's first ever PrEP in Black America Summit for and by Black advocates. We had an overwhelming majority of folks to attend that summit in person and virtually. And that led to the institutionalization of our first ever For Us, By Us report that outlines a master plan for HIV prevention in Black communities. And that report was derived through very strategic dialogue, bidirectional communication, conversation, stimulation, motivation, through folks who attended that convening. And so what it helped us understand were Black-centered, Black-led, community-derived strategies to address HIV prevention in our communities. We identified primary barriers that affected access to PrEP in the Black community. We discussed the foundations of a national PrEP program that may seem a bit dry in the context of these efforts undertaken by the current administration. We discussed strategies for effective public health messaging, opportunities to support long-acting HIV prevention modalities, racism and discrimination, all of the isms that serve as structural drivers of negative sexual health outcomes in the Black communities. And most importantly, our solution-focused conversation talked about provider education and other opportunities for intervention. And so with that were 3 key recommendations. The first of which was to energize the Black public health workforce to lead the HIV prevention response. Key takeaway message: the messenger matters. To that end, educate. There was a thought that there is still this chasm of lack of knowledge around HIV prevention, specifically PrEP, as an evidence-based HIV prevention strategy to prevent HIV. And then lastly, support this nationally funded PrEP program. And so through our conversations, there were additional efforts to address not only advocacy and mobilization around Black people's engagement in HIV prevention landscapes, but we wanted to also understand what was missing from the prevention landscape. So we hosted a pre-summit to the 2024 Biomedical HIV Prevention Summit. And at that summit, we hope to discuss recommendations and strategies to increase awareness and involvement in HIV prevention research among Black communities through a consensus-building dialogue. And through that bi-directional engagement, we hoped to develop what was the bare bones of this advocacy plan to support dissemination, engagement, and adoption of this first ever Black-focused and Black-led HIV prevention research agenda. And so we took that conversation, right, at the end of the HIV Prevention Summit conversation, we built the building blocks of this national HIV prevention research agenda focused for Black communities. We took that out into communities of Black stakeholders throughout the nation. And we had conversations with those folks to refine the building blocks of this research agenda. And here are some excerpts of what folks had to say. Folks said it is time for HIV prevention research to center Black lives. It is time for grant-making processes that limit Black innovation and ignore key cultural considerations. It's time to consider those amongst us in Black communities who are not included in this space as you draft this report, a call out for Black collectivism in this framework of HIV prevention. Most importantly, community is not an afterthought. We are full partners in research or nothing at all. And lastly, Black people means all Black people, regardless of our birthplace, the language we speak, sex at birth, or gender identity. Here is where we went in our long summer of engagement with Black communities to further refine the building blocks of this national HIV prevention research agenda. As I mentioned, we left the pre-conference with just a bare bones skeleton framework that was representative of thoughts of people of means, people who could make the means to come to a national conference, to be engaged in a conversation and contribute their thoughts to what should happen or what should be contributed to the development of this research agenda. So advancing the movement stands as a testament to what is possible when voices shape the narrative, when Black people's insights drive innovation, and when our communities are empowered to co-create strategies meant to serve them. This is an innovation to reimagine HIV prevention through a Black lens where culture is data, where community is science, and where healing is revolutionary. And so we'll take care to include a link to the Advancing the Movement document in the link or as a follow-up to communication from this webinar. So just a bit on some of the overarching takeaways before we hop into follow-up discussion. Here they are. So it's been determined that funding gaps dominate. Virtually all members demanded direct investment in CBOs as a truly key component of Black-centered research. Without resources, communities cannot set the research agenda or staff their own principal investigators. True to our culture, Black people advocated by us, for us. Over half of sessions talked about Black tokenism, emphasizing or re-emphasizing what we've always known, that Black leadership needs to be involved from the top to the bottom, from designing research, conducting the research, analyzing the study findings, and collaborating with other Black researchers was a near universal mandate. Persistent mistrust. No matter how much folks sort of want to advance this conversation around Black people moving beyond what is a persistent driver of mistrust in our community, Tuskegee's shadow remains reinforced by ongoing structural racism, homophobia, transphobia, and efforts to earn trust must be sustained. That medical mistrust isn't merely an expression experienced by Black people, but it is a thought that is pervasive in Black communities, bestowed upon us by the historic systems of oppression that limit our ability to show up, to be transparent, and to engage in reciprocal relationships with medicine and science. That research needs to be holistic and involve intersectional solutions. It isn't just research. People aren't just the subjects of research or participants in research, but many participants wanted to see the address of other concomitant issues addressed through participation in research. And that involved the integration of mental health, that involved access to wraparound services. When we talk about all Black bodies being incorporated in research, that's a representation of older adults, not simply defined as a cutoff of 65 years. That involved our trans siblings, that involved women and other often overlooked or excluded groups within the Black community. And then a dialogue near and dear to my heart, pipeline and mentorship. Participants readily and repeatedly said that new Black investigators need scholarship, need training, and robust mentorship to lead the pipeline. Long-term capacity must be built, starting with our younger development of high school scholars, undergrad, and onward, as we see the whitening of the HIV pipeline. And in the current context, I shudder to think what that will look like in just a few short years of the current regime. So here is the nuts and bolts of the Advancing the Movement HIV Prevention Research agenda, the Black Power framework, and it's overviewed here. So P for pipeline and mentorship programs, O for ongoing direct funding, 2 CBOs, 2 Black investigators, 2 the Black community in the lead, widespread education on PrEP and HIV science, which ties directly to our For Us, By Us PrEP report that was derived from bidirectional conversation with members of the Black community. E for empower the Black community, the Black public health workforce to lead not only the HIV movement, but specific to HIV prevention research as well. And the R for a reform of a policy for this national PrEP program. And so within this Black Power framework, there are actions for researchers and institutions, there are actions for funders, and there are actions for members of the Black community to further the implementation and reach of the Black Power framework outlined within this Advancing the Movement call. So I can stop there and thank you all for your time. I'll kick it back over to you, John.
So now we're gonna go into our moderated discussion. we have obviously Danielle and myself, but we have another esteemed guest with us, Dr. LaRon Nelson from Yale University, joining us here, who was at our launch on August. Oh my God, we're not in August yet. April 8th. Sorry, I want Leo season to come quickly.
No, we
April
don't. No, we
8th.
don't.
April 8th in Atlanta, Georgia, and has been a thought partner with Danielle, myself, and Piba. And we just wanted to have him be part of this conversation. Yeah, so I will kick it over to Danielle. I think she has our first question.
Sure. Dr. Nelson, do you want to offer brief remarks before we hop right into our, as John described it, moderated discussion?
No, just to say I'm super excited about what PIBA has developed. I'm happy to be here to be part of this discussion and this launch. And yeah, I'm ready to go.
All right. To that end, this research agenda highlights a pivotal moment in Black history in HIV prevention efforts for Black communities. Can you and John speak to why a Black-led, Black-centered, and Black-focused research agenda is particularly urgent in our current socio-political context?
Want me to start, John?
Go
Okay,
ahead.
yeah. Well, I mean, first I will say that, I mean, since I've been involved in HIV, we've been talking about disparities for a long time and investing a lot of money into research and programs that have not really done much for us. I mean, it's done some things for some people. Folks can definitely say they benefited from some of the advantage, but overall hasn't really paid off for us. And we can't afford 10 more years of it not paying off. Uh, when it doesn't pay off for us, it means somebody gets HIV who didn't have to get it, that somebody uh, does not get medication that they should get access to, that somebody gets sick when they shouldn't, that somebody dies that should not have died. And that is disproportionately us, disproportionately Black, disproportionately Southern. That cannot, if we continue to invest our people resources, the time we give the people, if funders continue to invest financial resources into these same infrastructures and these same people, we will not get anywhere. And given what changes are happening now, I mean, it's this federal system, they know that these changes will mean more of us will get HIV, more of us will die. I mean, that's what it is. And so it is urgent. Like we have to take control of this now. And I think the playbook has to be different. It has to be Black led, right? It has to come from people who understand what it is to live the life that we live. Because we thought other folks could understand it. Maybe they try, but they've not gotten it right. We can't outsource that anymore. That has to stop. It has to be Black centered. It can't be watered down. It has to really be focused on the ways in which the world we want to live in, the way we want to be in in America, on Earth. So that has to come from us. And then I think the third thing is it's the control. We have to have control over, like you said, then what we design what's designed, how it is implemented, and how it is resourced. And I think without that, and maybe this is me being cynical now,
Or not?
yeah, just it's if folks could have done it, it would have been done. Or if they wanted to do it, it would have been done. It's not done. We have to take this on as our job to save our communities. And it can be done. We spend a lot of time building resources and a capacity of CBOs, of scientists, of practitioners who we could all do this. We have to organize ourselves. We have to be coordinated and make sure that we get it done. So I think that's why it's not, because we already see that the old playbook has not worked in our benefit, and that these new folks who are running things are completely intent on making sure that this epidemic hurts us even more. And we have to stop it.
Thank you for that. And I hope that you'll talk about what your efforts have looked like to further change this paradigm of the continual persistence to support these outdated frameworks that don't, support Black communities, for lack of a better phrase. But John, can you talk about your thoughts on this? Why is this HIV prevention plan needed more now than ever?
So this is, as Laron said, like these attacks that we've seen, been negatively impacted by, experienced, are intentional. They are intentionally starting a genocide against marginalized communities, obviously Black people being one of them, Black communities being one of them, right? This administration has been attacking anything deemed DEI, or in their words, woke ideology, right? So it's now time that we double down on solutions that are rooted in community and centers our lives and experiences of the Black community in the United States. And this is exactly what this research agenda does. These health systems, these playbooks that Laron was talking about, were never established with us in mind, ever. It was created for white, Anglo-Saxon, Protestant, able-bodied, cisgendered straight men, right? The mourning period is over. Right? 100 days have passed us, right? We need to start rebuilding these systems that center our lives and benefit our people. All this distraction and destruction is an opportunity that we need to implement this agenda and rebuild, right? I'm gonna do something I've never done before, is give a sports metaphor, right?
Uh-oh.
Sports teams, when they've been losing season after season after season, they have what they called rebuilding seasons, right? Where they rebuild, they coalesce together, they bring up new talent from other markets and just build the infrastructure anew. And I think that we are in our rebuilding season. We need to take this destruction as an opportunity to build something that our people need. Right? Maybe it's the New York Knicks being in the playoffs that's giving me the inspiration.
Wow. Y'all got one playoff season. Chill out.
We are in our rebuilding season, and this agenda will help us build what will benefit our people.
And thank you for that. There's
Can I
so many
mention something?
follow-up questions. Yes, you can.
Yeah, because something John said about rebuilding, I think, this goes to your question about why it should be Black-centered and Black-led. Because I will say, like, for decades at least, even back like when there was this organization in New York called People of Color in Crisis, POCC. It was fascinating place. And that's actually where the Black Gay Research Group got started. I was part of that initial group that had formed at POCC in that leadership. And even as far back as that was at least 20 years ago now, the call was about building economics and community capacity. And that always never found its way into the research sphere. It was always kind of like something you put to the side. That's not what we do. That's what folks have been calling for. So it was, to me, it was like an inability to really understand the need. Like there was a need that was one that was part of it that was acceptable to whoever the power was, who would say this is a legitimate need, and the other just were always considered not legitimate needs. And I feel like this is the same thing we have now, is the idea where the investment is going, that it shouldn't just be a new HIV product, right? Pill, device, test, whatever it might be. But it has to be an ecosystem that responds to the needs that folks have been saying, this is This is the problem. The not having access to the pill isn't the problem. It's a need, but it's not sort of the whole thing. Like there's a
Mm-hmm.
larger need here that is not being addressed because we said we can address it. But I'm not sure how seriously anybody has tried to address it. Even some more recently, maybe there's been some light attempts to. But in general, they just not addressed it because folks have been able to say that's not what this is. That's not important. It's not modifiable. Whatever the language is, it all served to say we're not doing that. Even though Black folks have said this is what needs to be done. And we have to get out of that mode, even if that means we don't work with some people we used to work with, or we don't seek funding from some folks who used to fund us if that funding is going to tie our hands and being able to do what we need to do. It will require a very dramatic mindset shift from those of us who are used to the grant way of doing things. You know, you write
Mm-hmm.
what the grantor wants. I don't know if that's going to work. If the grantor don't want what we want, I'm just not sure it's worth us spending our time applying to do what they will own to fund us to do. And I think we can find ways to do that, but yeah, it has to be different because the rebuild, it can't be a replica of the old model. It
It
really has to
can.
be a new model that we envision.
Mm-hmm. And God bless, the old model, as you call it, but Black folks weren't overrepresented amongst the scholarship and the PI ship represented in that old model. Let's call a spade a spade. Less than 2% of NIH funded investigators are Black people. And when you talk about super PIs with more than one R01, Black people still aren't represented in that scholarship. So I can't say how much sorrow I have for the old model, but I am excited to the point that you mentioned about something new,
Mhm.
something that really centers the lived experience of Black people. And you talked about the old way not working. It's been 40 years, y'all. 40. And in 40 years, Black people are still not in the lead of scholarship and investigatorship of public health issues that directly affect our community. And we should be asking ourselves, why? And then we should be adopting frameworks like the Black HIV Prevention Research Framework, the Black Power Framework, as a methodology to help move us forward.
Mhm.
And so, Dr. Nelson, I'll put you on the spot, and I'm hoping that you can talk about some of the efforts that you've been leading to bring us something new. As a seasoned investigator within an infrastructure not led by us, but highly dependent upon Black bodies, what are you doing to lead the ushering in of something new?
Wait, what do you mean by seasoned? What does that mean? Like,
Seasoned. You're an expert. You're well published. Seasoned.
uh, yeah. So, yeah, I mean, so as John mentioned, I've been engaged with Kiba at least 2 years now. I think since Croy,
Mhm.
when it was in Denver. I think that was our first conversation about,
Yeah.
and so really following what y'all have been learning from your work and your sessions in communities, and just thinking about what would it look like for a platform for research, HIV prevention research that was by Black people, focused on Black people, and uh, and that was centered or anchored in community-based organizations. And so what we've done through history, which which has also been a part of this work with y'all, is develop a community-based clinical trial network that is focused on areas, communities, and organizations that serve and are led by Black people. Because the questions that need to get asked and answered in general aren't being asked and answered. Not the question that they want, because the mechanism is, I mean, you can do it as a R grant if it's a small enough project. If it's a big question that needs a lot more resources, you have to go to some other infrastructure to get that to be done. And that has challenges for Black folks. One, you're not going to be the one to decide whether or not you do it. It's going to be somebody not Black, doesn't understand your community, probably doesn't really care. It won't be done timely. And so, part of the challenge is the what would you call it? Um, the interest, I think, of research super infrastructures, called super PIs, but these research super infrastructures don't align necessarily with the interests of communities.
Mm-mm.
They take a long time to figure out like what to do, and then they figured out what to do when they shouldn't be figuring out what to do. We should be figuring out what to do. And we
Say
don't have
that.
a long time to wait to do this because our folks are being affected by this right now. And so the model of taking a long time for some elite group of folks to figure out what to do in your communities, that's awesome. Uh, Without sufficient input or direction or control, I think has to end. And so I've talked with folks, even at the meetings that y'all will hold about come on, LeBron, what's up, man? Why is this thing not moving? This other stuff that I had going on. We should be doing this. This should be done already. And why aren't we doing
Mm-hmm.
it together? And that was a real question. If we were doing it, could some of the questions that we wanted to be asked been asked, and answers that we needed been answered, and the work could have been moved quicker and would have been work that was seen as more relevant. And so that is where we're thinking about with history is a community-based clinical trial network, focus more even on implementation. I know we discussed this, Danielle. A lot
Ad
of
nauseam.
is in the efficacy world, which is important too. But part of, I think, the gap that we face as a Black community is not that we don't have efficacy on products, the new preps, the new treatments. Those studies have been done. They've not had an impact on us because the issue is not necessarily in not having enough discovery. It's in the delivery. What is
Mm-hmm.
keeping discoveries from making an impact in our lives? And that requires different questions to be asked by different people and then different strategies to close that gap. So that's what
Mm-hmm.
we're working on. We're actually meeting in LA in June, I guess next month, 25 and 26, to really have a very elaborate nuance of the launch and thinking through this as a lead into the NASEM conference. But I'm saying that is because it wasn't something I just sort of came up with because it was an interesting idea. It was really trying to take seriously what the power framework was calling us to do and listening what people said they wanted and not sort of saying, this is all the reasons why you can't do this thing, right? Well, because you need this and because you need this and because you need that. But the question was, how might we do this? How might we give give the people what they asked for? And
Period.
the question that drove us. And I think if we ask those types of questions ourselves, not limited by the constraints of the old way, and just say, what if we could do that? Like, how might we get this done that people said they want done? And I think it's possible if we collaborate and work together to make sure it can come to fruition. So that's one of the ways in which we're trying to think about how we take this agenda and convert it into action.
Thank you for that. If I could, a follow-up question. So the Black Power framework outlines clear communication or clear recommendations for pipeline development, right? We know that there are fundamental kinks in the pipeline development that prevent the centering of Black innovation, that include ongoing funding, widespread education, empowerment, and policy reform. So I'll put a pin in the policy reform piece for John. Considering current political climates, which we know are hostile and profoundly anti-Black, in addition to funding uncertainties, what creative or innovative strategies do you recommend to sustain the momentum of this agenda, even in times where there are limited resources and uncertain budgets?
Yeah. Well, I would say that I mean, the grant mechanism is still a way to do it, the federal ones, but unreliable at this point. And then some of what you have to do to get them are they sort of neuter them. You won't be able to do anything much with it. If you can't say
Not a
black, you
thing.
can't say gay, you can't say trans, you can't then there's not much you're gonna be able to do with it. But that's one way. I think that a different model, a new model is sort of looking to uh, the private sector. Uh, there's a way to think about this disruption as an opportunity to envision in ways that this creates value for Black folks, Black families, Black communities that can attract investment into what we want to do. We just have to learn how to make that case. I will say, I was even at the PIBA meeting in Atlanta, that launch, there was a conversation in one of the sessions that someone said, how do we do that? Because we know how to write grants, which is true. Like I've been trained exquisitely in how to compete and NIH grant review, right? And
The
I know how to,
seasoned.
yeah, okay, that's what it is, season. But that can't be the only, that's why many of us are in this predicament, because that was our sole source. We knew how to get that money from that source, and we didn't know any other way to do it. And I think we have to experiment with getting sophisticated about other ways to do it. I met with a colleague of mine who I'll meet again next week in New York. And I was telling him about one of the studies that I lead. It's HPTN 096, which is one of those studies that has not been terminated, but it is not, the funding for it has not moved in months. And so effectively, it has stopped stuff. People have been laid off and contracts have been paused. So that work is in jeopardy to date.
What does
But
096 hope to understand?
okay, so HPTN is an acronym for the HIV Prevention Trials Network. So HPTN 096 is a integrated multi-level strategy, meaning community level, organizational level, healthcare facilities, and individual level. That is designed to see whether or not if we implement that in communities, we can improve uptake of Black men and sex men who enter into healthcare, who are prescribed and adhere to PrEP, and who are retained in care and virally suppressed. That was going to be done in Dallas, still slated to be done in Dallas, Montgomery, Alabama, Miami, Florida, and Fort Lauderdale, Florida. So that's HPN 096. So I was talking about the challenges we were facing. This is a guy who's in private equity, and he said, "Well, how much money is it?" I forgot
I
how
was
much.
gonna say.
Yeah. So I don't know. I gave a big number, and he was kind of like, "Well, that's not $1 billion, but like 10 million, 50 million, 100 million. Like there's money. My portfolio is bigger than that." Like, and so the issue is not whether or not there's money to fund the study. The issue is what's the value
Yes.
proposition of doing the study. Because there's
Yes.
people out there, if you can communicate to them what is the value. And sometimes the value is the return, which is not like many of us are not used to that language or that concept. But he was saying funding to do this stuff that's going to have an impact on society, like the money is there. But you have to know how to make the case. The folks who know how to make the case are folks who are interested in Black life and Black wellness. And so the folks who are interested in that need to know how to make the case to the right people, because you can get the investment. I'm not sure that we've done that much in HIV prevention or treatment research. I think that's a new lane that we have to figure out, can we be in? Can we be in it ethically? Can we thrive in that to get the resources that we want to do the work that we want to do, how we want to do it? So to me, that is the newer approach. It is underexplored, maybe in some ways just scary. So we need
It is.
folks, Black folks who understand that world, who we can trust. We might not be able to trust everybody, who can make sure we have sufficient guidance about how we do it without getting played in the process. Because it can be cutthroat too. But I think if the only option is go back to NIH or CDC, we're doomed. And so we got to look at other sources.
Expeditiously. Thanks for your thoughts on that. John, did you want to weigh in as well?
Yeah, so when it comes to, yes, policymakers, we need to expand the definition of policymakers, right? It
Oh,
in- more than likely, we usually talk about federal policymakers, Congress, administration staff, CDC, NIH, HHS, all of those. But we also need to consider state, city, and local policymakers, right?
mm,
Because rebuilding this is going to start from the bottom up, not from the top down, right? So when we talk about pipeline and mentorship, and we also need to include universities in that. There are policymakers at the university level as well, right?
mm-hmm.
That make policies that impact research, right? So when we talk about pipeline and mentorship, funding, widespread education, empowerment, and in the public health workforce and reform policy, right? It can be done on all of these levels. The federal level might not be the best way to start right now, seeing as they literally passed the bill yesterday to cut Medicaid, $500 billion in
It's
Medicaid,
sickening,
right?
sickening.
So we still have champions in Congress, right? The Congressional Black Caucus, Raphael Warnock, who we heard from, right? We still have people in Congress, but they are in the minority right now. So what are creative ways that we can, or strategies, right, to sustain this momentum, you asked? We need to grow our own from what we have, right? Mentorship networks within the system that we have. Pairing experienced Black researchers or seasoned Black researchers with emerging talent, right? We have a seasoned LaRon and we have an emerging talent, Danielle, right on this call, right?
Mm-hmm.
Pair these groups together. We had a convening in Atlanta, April 8th, where we had 100 Black researchers in the same room. That is the first time I've experienced that, right? In the same room. There is so much collective knowledge and power in that room. And we have folks in their PhD program, DRPH programs, MPH programs that are coming up, right? So building this new infrastructure is going to involve not only the seasoned professionals, but also those that are coming up. I'm gonna be using seasoned this entire week. We also need to tap into alumni networks and HBCU networks. As we know, this administration is attacking HBCUs as well because of their wokeness, which is against whiteness ideology, right? So we need to engage alumni from HBCUs and public health programs, right, to build up. And we need to leverage unrestricted dollars and dollars we haven't gone for before, right? As LaRon mentioned, right? Pooling funding models, coordinate with philanthropy, private equity, other social impact organizations like JP Morgan Chase has a social impact section. Like all major banks have a social impact kind of arm to it or a foundation arm to it, right? We need to be able to package what we're selling in a way that impacts them, that resonates with them. The same way we package a message to Republicans in Congress, package a message to these private equity, philanthropy, social impact organizations, right? And we also need data for the people, right? We need to develop and share community-controlled dashboards using survey tools, whatever tools that need to be used to create these dashboards that talk about how these changes in the administration are impacting our lives. Because there's so many reports out there from KFF, from all these places, but they don't focus on a particular population, right? We need a dashboard so that we could pull from that is not threatened to be taken down if an executive order is signed, right? We need to be able to have this data readily available of how these changes or what is happening in our community that is separate from what we currently have.
And I think that the localization of it is key also. I'm not a policy person, but I will say that, I think part of what has been successful to date about the HB 10096 study, as an example, is that it was very local. I mean, we sort of frame it with national data, but we're like, this is what's happening in Montgomery. This is the deal in Fort Lauderdale in Broward County, and in Dallas County, for example. And these folks set up these coalitions who really talk to local stakeholders about what's happening here and getting people activated and energized about what's happening in their community and what to do about it. Because those representatives are the ones that are in DC, but they have to respond. Hopefully they do respond to the pressure they get locally. Because I can't vote for the people in Dallas or Broward or Montgomery. Those communities can. And so I think John's point about where the advocacy happens and rethinking who is the policymaker, that it can't just be we only think about the folks in DC when they're in DC, but it really is built on the local work. New York, for example, is maybe a good example of a lot of the work that I've done in New York. None of it came from the federal government. It was from the state of New York and New York City, because the people there make it acutely clear about what their needs are and demand that it get addressed in ways that I think other jurisdictions could also learn from to generate resources to support their work.
And thank you both for those keen insights. It's interesting to hear you say, John, about this reconceptualization of who we believe policymakers to be, and amid all of these national cuts, specifically in LA, we were faced with cuts to our entire health department sponsored HIV prevention portfolio, but we understand the power of advocacy and mobilization, and it's essentially how PIBA got formed. So I think that's a great way to understand how different people are policymakers, advocates, investigators, both seasoned and not. I wanted to follow up to ask, so the Black Power framework, I talked about how it outlines these clear recommendations for pipeline development, ongoing funding, education, and things of that nature. How can communities, researchers, policymakers that you mentioned practically integrate this framework into their current practice?
What do you
How can
think?
that happen?
Tell me what you think. I'm curious.
I've said what I think ad nauseum, right? I think so. The framework sits in this nexus between advocacy and mobilization. It sits in the nexus between policy, and it sits within this nexus of research. No one pillar more valuable than the other, and each of which are necessary to the key implementation of this framework.
Mhm.
So as someone who writes policy, as someone who conducts research, as someone who is an advocate, I can see my role in each of those positions to center this agenda. It gives me the tools within which I can design better studies. It gives me the policy language so that I can communicate to other folks who may not be up to speed on the general or specific need of PrEP, Black-led, Black-focused, and Black-centered research, and how this common theme that has been a theme that's been prevailing since you said 20 years ago, and I'm sure before then, which leads me back to my question, what exactly is the BGRG? For the folks in the webinar. So put a pin there. And as someone who is a staunch advocate of all things Black-centered and health equity informed, this research agenda gives me the tool to arm myself with to go back out into community, big C. So I can utilize it at the university level, the CBO level, and the ground level with other advocates that do this work. So I am from the top to the bottom, and while it may be focused on local action for Black populations in the US. Who's to say it doesn't have relevance for Black communities that are ex-US? You know, those conversations are beginning to take shape, and hopefully we'll continue to explore what that looks like at the International AIDS Conference this July in Rwanda. So those are just those are one woman's thoughts from the field. I'm interested in hearing from you and John as well.
Yeah, that's wonderful. I mean, I echo everything that you said. I think I would approach it quite the same way. And, I would encourage everybody to take up the agenda and think about how they incorporate it into their work and taking advantage of spaces where we can be together, virtual ones like this, or
Yep.
in-person ones where we have more time to figure out what part can you do and what part can I do. So I can think, for example, there's people on the call who are deans of schools. I saw the list of folks who checked in. They literally run academic programs. Could they take this and how do they incorporate this into how they teach their students? If they're in medical school or nursing school, there's an infectious disease model or wellness model. How they incorporate this to think about how we help reduce inequities through the students who they train in their programs, who are either going to go out and be serving somebody in the clinic or be doing research someplace. Or how do they incentivize faculty members to do research that focuses on addressing inequities with students in programs? Or CBOs who say, yeah, this sounds good, but we don't do research and we're in, I don't know, Kansas City, Detroit, I don't know, Jacksonville, Florida. There are no big HIV research centers here. Like, that's okay. We got Black researchers all across this country hoping to partner. And like we can actually get this done. Like that's not even an issue. So think about what can I do as a CBO? We're interested in this. We'd love to learn it. Or we have capacity, we just don't have the partnerships. How can we make that happen through partnerships with some of the schools who have access to researchers who can do it? When we went to Houston, Texas, for example, that was a question that came up. Who's going to do it in Houston? I was like, no, we got to do this in Black organizations, Black-led organizations. Like I won't get into that. That was what we wanted to do, right? And so the Normal Anomaly, for example, is an organization in Houston, Texas, that said we have no experience in the stuff you're talking about. We don't do studies, we don't do recruitment, we don't do data collection, specimens, processing, none of that stuff. But the question I asked earlier, not about the constraints, but how might you be able to do it, right? It's possible, right? And so an organization who had zero experience, not even entry level, zero experience, actually was, I would say, probably the highest performing organization in terms of speed of the work that we had done across 4 different communities. And they had never done it before, right? All this is possible. And I think one way is concrete is figuring out where you think you might fit into this and not say all the reasons why you can't do it, but ask yourselves, how might we be able to do this? What connections do we need to make? What partnerships should we build? And I think PIBA can be a platform if you don't know how to do that immediately. I think there are ways through PIBA, through history, United We Rise, we can figure out ways to help make it possible. But that's sort of my initial thoughts about it too.
And that's
Yeah.
great. Before we transition to John, can you tell the folks what BGRG is?
Oh, sorry about that. Yeah. So BGRG is the Black Gay Research Group that started maybe 2000, 2002. And it's sort of in some ways sort of a precursor to this agenda. We came up with an agenda years ago, but it was focused exclusively on Black gay men at the time, Black men who are sex men. And so that was a group that when I mentioned POCC, that was an organization that since closed, that was in Brooklyn. But I mean, that group was pulled together, researchers, policymakers, so like Ernest Hopkins, Cornelius Baker, who passed away recently.
Rest in heaven.
Yeah, Leah Wilton, many people, Marlon Bailey, who's on the call. So we didn't convene that. The community members who run the organization pulled that together and said, we got to do this. And so some of the same things that we talked about then are still we're talking about now. And I think what we didn't do then was have an agenda that spoke to everybody in the Black community. Ours was more focused. And I think our agenda did rely on exploiting no, leveraging the
Mhm.
existing infrastructure that we thought there's ways we can make this thing work for us. And so that's what BGRG is,
Thank you for that.
for an organization in the movement.
Thank you. It's certainly important to acknowledge the historical events and the shoulders upon which we stand as a mobilization group, in this work. So thank you for providing that context. John, your thoughts?
No, yeah, I just want to echo what both of you said. It's like that we often see communities as one pillar, researchers as one pillar, policymakers in one pillar, and communities sometimes think that they can't do research, or researchers think that they can't advocate to policymakers or be policymakers, right? Or communities can't write policy, right? Like we need to kind of like get rid of that old mentality of like, I need to stay in my lane, right? And if you're equipped with the Black Power framework, anyone can do the pipeline development. Anyone can do the trying to find ongoing funding mechanisms, right? Widespread education, right? That's usually on the job of communities to educate, right?
Mhm.
But researchers need to educate, and policymakers need to be educated and educate their fellow policymakers about what these things are, right? Empowerment. Anybody can empower communities or workforce or whoever, right? We need to really kind of de-silo all of these and specific things that, and to mimic on what I talked about earlier, was start local to build power. Local wins are faster and more visible, right? And they build momentum for major policy shifts.
Mhm.
Push for state level leverage, right? States control Medicaid, licensing, public health funding as well, and can pivot innovations. I was at the New York City Health Department when the governor and the mayor put an influx of ending the HIV epidemic money into the city and state health department. This was in 2020, this was in 2015, I believe, before EHE on the federal level was a thing, right? It's often said that the New York City EHE was ETE, is what it was called, is the basis of EHE, the federal.
Is that so? I don't think I've ever heard that, but
Bye.
I'll let you
Um,
have it. I think I've heard that one.
we
Folks,
need
come in the chat if you've
to
heard that.
We need to use the Black Power framework to organize our platform and our policy goals, right? Community members can create policy briefs as well. Researchers can do policy briefs, right? And build toolkits that include demands, develop scorecards, right? Community can scorecard researchers, researchers can scorecard whatever entity, federal, state, local, that they want to, and vice versa, right? We need to integrate these three often separated ideas and populations into one, because we can all do it all. Like I'm an advocate. I work with policymakers. I develop policy. I'm involved in research. I don't do research, but I am involved in research, right? And I understand how it works. Right? So like I can dip a toe in each of these kind of populations, and we all can, right? The last month I have been working with researchers and training them to be advocates themselves about these NIH cuts and NIH changes in policy and whatnot, right? You have a voice too. You are a constituent too, right? Like you need to use your voice.
So just a quick follow-up for you, John, our resident policy expert who dips toes in all of the things, apparently, including making up this statement about New York. I'm gonna let it slide because you said the Knicks were in the thing, so I'm gonna let you have it. So the research agenda recommends advocating for a comprehensive, federally funded PrEP program modeled after Ryan White. From your perspective, what are the primary policy barriers to such an initiative? And how can advocates strategically navigate those barriers?
Yeah, so the obvious barrier is political resistance to expanding
Huh.
public health programs, right? That is obviously the major barrier, right? In today's polarized climate, federal expansion of healthcare is non-existent, right? And they're focused on marginalized communities, and we often are met with opposition. About ideology or identity politics or what have you, right? We need to address that this is a thing, and they're trying to dismantle the public health system, literally, brick by brick,
I just don't
right? So
understand.
that is obviously a barrier. Stigma and opposition around the topics that we all on this call care about: HIV, Black people, sexuality, right? The populations most affected by HIV are Black communities, LGBTQIA plus communities, and more, right?
Women.
Women, Black women specifically, right? And are always subject to stigma and discrimination that translate into hostility often, right? A fragmented health system, which is obviously even more fragmented now, right? For a national PrEP program to happen, we need to harmonize Medicaid, private insurance, HRSA, CDC, NIH, local health departments, all of which are crumbling in front of our eyes, right? So it's going to be difficult. It's going to be it's an uphill battle to get. And we have champions in Congress who have written what we see as like what a national PrEP program could be, right? A group of advocates, got money for the CDC before all this craziness happened, got money for the CDC to do a pilot program in 5 jurisdictions, which PIBA was influential in ensuring that the majority of those jurisdictions were Black majority. Houston, Baltimore, right, were some of the cities that were involved in that 5-city pilot, which we don't
Oklahoma.
know where that pilot is now because of everything that's happening, obviously. But it's gonna be a huge multi-sectorial effort to get a national PrEP program, right? But what can advocates do? Build cross-sector coalitions with unlikely allies, right? Partner with Black churches, conservative-leaning health groups, right? Rural healthcare. The healthcare of everyone is at risk at this point. Everyone. Cancer, Alzheimer's, hypertension, all of it is being targeted, not just HIV, right? And when you talk to people in Congress, HIV is not even their priority right now. They're talking about cancer. They're talking about Alzheimer's. They're talking about other diseases. But what we need to do is we need to pair ourselves and partner with some of these other health advocacy groups, right? We cannot be in this HIV silo anymore, right? Because guess what? HIV is not the first thing on their priority list right now, right? Braidwood versus Kennedy is not all about PrEP. It's about coverage for prevention. So that's breast cancer screenings, colon cancer screenings, high blood pressure screenings, right? We need to peer and partner with these health advocacy groups as well, because they see us and remember, before this all happened, HIV is seen as the rich disease, right?
Although we would argue otherwise.
Compared to other diseases out there, right? So I have been in meetings where they're like, HIV gets enough money. We need money for malaria. We need money for this. We need money for cancer. We need money for this. HIV got enough. I've been in meetings where they have said that. We poach each other, right? We cannibalize each other. But what we need to do is we need to come together. Again, as I'm going to keep reiterating, focus on state level advocacy, right? Center Black lives, Black voices and lives in policy development, and use stories as data. These stories, like in Congress, they really don't care about the humanity angle because they're not human. They don't care about whether we live or die because this is intentional. They want us to die. It is obvious that they want us to die because they don't care. But we need to collect stories about our experience because people will listen. Other funding lanes will listen. Private equity, etc., will listen to these stories if we collect them. And that's all I got.
Thanks. You said a lot. You said a lot. As we sort of wind down our time, I wanted to take the conversation back to you, Dr. Nelson, to comment on what you think can be done to hold large institutions accountable for ensuring that funding reaches Black-led orgs without dilution or excessive administrative burden.
Well, maybe it will depend on the institution, but I think from a if federal government, if we start there, since they are a large funder of most things, I think making sure that your local representatives know what you're doing, know what investment it requires, and that they can also hold those institutions accountable. We had to do that with some studies to say, here's what we're trying to do. Because this is not the government's money. It's not Elon Musk's money or Donald Trump's money, or it is public money. And it needs to be treated as money to address pressing relevant public issues. And so they don't like getting calls from Congress people. They hate it. And so you should but if they don't, honest to God, this is a terrible example, but it's a real example that when my parents would go into the hospital, which wasn't often, but if they got sick, like we had to have somebody who knew somebody who was going to pester people at the hospital, because they were always worried that if nobody's paying attention, these people going to do what they're going to do to you. And there's somebody there annoying them, and not that you're really upset, it's a strategy. Because if you take your eye off it, people are going to do what they want to do. There's some truth to that. But I think also in the system, I think sometimes these folks think it's their money and they're going to do with it what they want. They don't have to be accountable to the public, and they have to be accountable to the public. And so I think making sure that our representatives who represent us are stewarding that in ways that say what's happening with Campbell's study in LA or Mead's project in New York or DC. Like, somebody needs to be putting that pressure on them. I think one, for accountability, because they can easily ignore us, to be honest, as an individual, not so much as a group, and they definitely can't ignore the people who potentially affect the budget, which is the second thing, is the money, because these folks respond to money. So whether or not it's an organization you're working with, a network, a university, like, you have to let them know that we don't need you. Like, if you don't get it together, we can do this someplace else, right? Because that's when they'll pay attention. I mean, if you look at what was happening, everybody knows this, with the DEI stuff, everybody kind of got quiet. Oh, well, we can change this and do this and maybe whatever. Wasn't much. Then they say, oh, and we're going to cap the NIH rate at 15%. Then all of a sudden, that was a thing, right? No, I mean, that's not a surprise. But I think it is the same thing. That's what these institutions respond to. So they have to know that we know that that's what they respond to, and we respond to the same thing. And so if they're not doing right by us, we don't need to invest our time in them. They can't do the work without us, right? And so if they are not going to be the stewards of our time wisely, well, we hold them accountable with saying the thing that you want most, you won't get, not from us or not on our behalf. I think, though, it's sad to sort of say that's the way, but that's as I can see right now, that is the way. It's political accountability on these organizations, these institutions, and the governments, and then making sure they know that if they mess with us, it's going to hurt. It's better to do right by us, because if you fuck with us, you're going to wish you hadn't done it.
That part.
Well said. Well said. I mean, there's no other way to describe it, right? Lots of these research studies won't advance without Black bodies. And
Yeah.
investigators are the direct link into communities. CBOs are the direct leaders in community that provide entree to these, billion-dollar research entities to come and access our people. So if we stand out front as shepherds and as stewards and as the voice of our community, then it presents an opportunity for a different conversation.
And
And
it
I
has to be
love
it can't be one that says, well, I'll do it. Like, we can't get played. If we say we're not doing it, then we have to not do it. This
we,
is why
as in
we can't,
all of us.
all of us, stop,
Yes.
right?
Uh-huh.
It's like the
Yes.
Montgomery bus boycott. No, we all walking. Oh, we
Yeah.
all giving each other. No, nobody does it. Because
Mhm.
that'll be the first thing is they'll sweeten the pot for one organization who'll take the bait, which sells us out, all of us out.
Right. Because they're in danger of closing doors and losing jobs or, a minimization of research infrastructure. But again, we are stronger together as history has taught us a fulfillion times.
Right.
There's a
So
question in the Q&A that
go for
builds
it, John.
on what you all were talking about CBOs. Like with funding cuts from Tommy, with funding cuts to CBOs and potential cuts to insurance coverage for PrEP, how can small nonprofits and organizations like them, AR Reps in Little Rock, Arkansas, build sustainability economically while still getting folks on PrEP? And one thing that you said really, and one thing I mentioned earlier was about coalition. And usually these small NGOs are fighting for the same pot of money, right? There needs to be a new model where smaller NGOs or smaller nonprofits come together and strategize together,
Yeah.
right? Come together. Like there are other small nonprofits that are dealing with the same exact thing that you all are dealing with in Little Rock, Arkansas, right? I live in New York, so I may not have the right answers for something happening in Little Rock or a smaller rural area for a small nonprofit, but we have collective knowledge and collective wisdom, and we can strategize together on what needs to happen and how other organizations and other nonprofits are dealing with these impending cuts and insurance and all of this stuff, right? I may not have the answer to that specific question about sustainability economically and whatnot, but I'm sure you all know smaller NGOs that you may work with in your region or in your or going to all these conferences or whatnot. Like tap into that network. Now is the time to tap into those networks that we've built going to years of USCHAs and years of biomedical summits, right? Like tap into those resources and kind of do like a community of practice and strategy session with these small organizations. But that would be my response to that question that came in.
Yeah, I think, if that person or the organization, I mean, history will be a nice venue to explore those kinds of topics of
Mhm.
what's the new business design that my organization can be exploring to help sustain us in the context of all these cuts that are happening. And sometimes it doesn't have to be like big dramatic things. I mean, I think part of the illusion is that you got to have a grand idea and have grand funding to do this grand test. And I'm not sure that's actually the case. I think there are ways that you can try innovative ideas, small scale, figure out where the pain points are, is it likely to work or not, and then get folks who will want to invest in that. I mean, the investment space is very different from the research space, the researchers require you, we used to say to get it granted NIH, you have to already have done the work already. And that was
Mhm.
almost true. You kind of have to already know the answer before you even have a shot at getting the grant and all this preliminary studies done. Because they are essentially no risk organizations or very low risk investment organizations at NIH. I just came from San Francisco about 2 months ago and talking to these different CEOs in the Silicon Valley. And they're all saying, yeah, everybody here got big because they failed. And they failed a lot. And they failed fast. And they figured out what the thing was. And so when people come there, like they're not so worried about an idea that hasn't been fully fleshed out yet. Like you got to try it, and you got to try it now, see if it works, see what's not working, and fix it up and do better. And I think that that model could work for us if we have resources, or if we can get resources to try things quickly without having it all figured out, especially if they might work in the real world. That's the real beauty of CBOs. Is this you have real laboratories, real world laboratories to see whether or not that has value for people. But I think there are ways to do it. I don't have the answers either in terms of what exactly would be done because it is contextual. But I think the approach of really believing that you have something innovative and then trying it and then seeing who might be willing to invest in that quickly and in some ways substantially.
That response gave me pause. And thank you for that reminder about how success is often built within this consideration of failure until we execute and implement the most appropriate model for the context. So thank you for that. As I'm dissertating and running different models and logistic regressions in R, I failed it quite a bit. So that point hit home for me as not only an advocate, but a doctoral student caught in the throes of just really trying to understand how my research may be impactful. We are unfortunately gearing toward next steps in our work. Thank you, Obi, because Lord have mercy on my soul. We're almost at the top of the half hour, and I wanted to not only thank each of you, but thanks to the folks. There was one other question in the chat before we close out. And Amber said, I believe that as researchers, we should always think of ways for interventions and programs to have longevity and to be sustainable without government funding, much to what we've discussed today. This person says there are many different ways to do this, but there are certain avenues that work better than others. This is one of the primary goals for my own research, and through my consulting work with nonprofits. So thank you for that comment, Amber. I think as a coalition, we're exploring the other strategies, and LaRon mentioned several other strategies that we should be considering, but to the point about an upcoming opportunity at History is that this is the prime time for us to come together and collectively describe what those opportunities could and should look like in this, framework of Black excellence. So stay tuned for more information. In the last minute that we have, I wanted to offer the opportunity to my co-panelists to close us out. Right, we have the Black HIV Prevention Research Agenda. Each of you have talked about how it will inform your work. Give us some parting words as we go and brave, this Trump 2.0 disaster today on Thursday.
Okay, maybe so let me just say, if you don't have this, get it, print it, we can mail you a copy, download it. I mean, it really is the blueprint. And I think if we follow it, if we really, really, really follow it and think about how we can do this together, we can make a difference in this epidemic in Black communities. I have no doubt about that. And some of what we said might feel daunting or risky or scary because we're used to this sort of safe lane. The safe lane has not benefited us. I mean, we have to try this thing differently. And it may be something that no one's ever thought about doing before. Stay in the course is not, it's not the business. It's not. And so I just want to just applaud you, Danielle, and John for your leadership in this. And thank you for giving me and my colleagues and my team a framework that we can use to make sure our work has more impact as we try to change the direction of this epidemic in our communities. I'll stop there.
Thanks for that, John.
Yeah, so this is not just about surviving this craziness about what's around us, right? It's about thriving in resistance. The agenda says the most impactful prevention approaches don't always require massive financial investments. What it does require is commitment, creativity,
Yep.
community leadership. That's the fire that we need to keep lit. And I don't know any other population, any other group of people that is more creative than Black people. So let us go on, go forth, keep fighting. The resistance is going to keep, we need to be resistant to all the things that are being thrown at us, right? But we're not going to give up. And someone put in the chat, what are the next steps for this? We will be coming back into the communities to present and to get more momentum behind implementing this research agenda. So that is what is next. And we will ensure to keep you all in the loop. If you have organizations, if you have professional associations, that group of researchers that need to hear this and need to be in the same room talking about this agenda and how to implement this, let us know. And we will be sure to ensure that we can make a space and a platform so that that conversation can flourish. So yeah, that's my word.
All right. Thanks everybody for your time today. I'll close us out by saying us or else. So stay tuned for more work from PIBA, from History, from United We Rise. We will be with you as always. Have a great rest of your day, folks.
And we will be sending the agenda via email. I see a lot of, can we find the agenda? We will send it via email.
Promise is coming with the follow-up communication to this webinar. So have a great day, folks. And thank you for your time. Great job, y'all.
Yeah, that was so fun. That was amazing.
That was great.
I'm excited for next steps. And Dr. Nelson will schedule a post-webinar meeting to talk about what I call phase 7 of this project. John calls like phase 59, which is our implementation phase and the stakeholders that we hope to engage as part of that multi-sectoral approach to make sure that you're involved in that and then explore other opportunities for history to be involved in that as well.
Okay, sounds wonderful.
All right.